Hi there. I'm Dr. Ajaya Kashyap, and I'll be talking today about a problem that affects a lot of women, that is, having large, pendulous breasts which weigh them down. The shoulders and the neck are in constant pain, and the posture also gets affected by the large breasts, which just hang and weigh the shoulders down. So, this problem is also called macromastia or gigantomastia when the breasts are really large. It happens in all ages and at all in all races once maturity has been reached. Oftentimes, however, they may happen when the pregnancy and lactation causes some hypertrophy and the breasts never go back down to their original size. However, there is something called virginal hypertrophy, and the youngest lady that I have operated on has been as young as 14 years of age. Her breasts were so big that they were bigger than her stomach, big enough that she just could not walk properly. The oldest has been well into her 70s. And I'll give the reason why I had to do the one who was well into the 70s. It was because her insurance initially had declined in another country. And when she came to me, she had already suffered from the problem for almost 40 or 50 years. And the first time she came back after having a reduction, she was skipping. She was so happy and felt so light. A petite little lady, maybe about 5 feet tall, thin, but with huge breasts. Now, sometimes it can happen to ladies who are overall big in size, but then the breasts become even heavier and weigh their shoulders down even more. So, irrespective of the frame that the individual has, if the breasts are disproportionately large and heavy and pendulous, they will affect the shoulder, the posture, the neck, and any amount of exercise that is done will be excruciating. Sometimes when men say, well, you can never have too much of a good thing, it's not true because when the breasts are too big, they don't look that good, and one is not able to exercise. So when the boyfriend or the husband says that, well, I want her not to have too much of a reduction, I often tell them that, think of exercising or walking with two large bags of flour weighing on your shoulders on each side. And certainly, when we do the breast reductions procedures, the breasts do look better, although smaller. Now, coming to what are the options for someone who has breast hypertrophy or increase in the size of the breast, so much so that they are uncomfortable. The first option, of course, is it possible to do it non-surgically? And sometimes, if the overall the weight is more, the patient is a little obese, some weight loss can help, especially if they are older, because a larger proportion of the breast as we age becomes fat and the glands become smaller in proportion. At a young age, when you have a lot of breast tissue, lots of glands, then even weight loss may not help. Now, once the weight loss has been there, one can assess if the breasts are still big and if they are just pendulous, meaning if they're just droopy. Those can be improved by just lifting the breast and maybe doing a little or no reduction at all. Now, the reductions that are done, there is no measure as to how much is going to be good for someone or not. However, most ladies like a big or a regular C cup size. The younger ladies usually like a full C, and the older ladies either a small C or even a big B. When the estimates for breast size were done, it was found that most men like a small D, most women a C. So, depending on what the symptoms are and how bad the pain and the aches are in the shoulders and the neck and the breasts, one can decide as to how much reduction is appropriate to still have a nice feminine look and have the proper amount of breast tissue, and also to get the relief from the symptoms. Now, the first thing to decide is if the patient can do non-surgical weight reduction as exercising gets really tough with the breast hanging down. If so, the first option, of course, would be weight loss. The second thing to decide is what kind of breast reduction needs to be done and how much. As I said, the amount of breast reduction depends both on the aesthetic sense of the patient and her significant other to some extent, but largely the patient or the individual herself. The appropriate amount of breast reduction because by the insurances, some places the insurances cover reduction, and they would give you a certain number depending on the BMI, the height and the weight. They'll give a number, say, you need to have 350 grams of breast tissue out when you get it done. Or if you are even bigger, then you may need 400. Some insurances go as far up as 500 grams from each side. The less amount may be needed for some people who have very pendulous breasts and are petite. And for those ladies, smaller reduction and a lift would give them as much relief as it would have given a bigger lady with big pendulous breasts who have a bigger frame overall. So that is somehow taken into account with the insurances as well. Many places, insurances do not cover breast reduction. However, the insurances started covering breast reductions in some countries because the subsequent amount of money that is spent by insurances over the health related problems because of large breasts is much more than the money they would have spent in approving the breast reduction procedure. Now, even when the breast reduction procedure is not approved, it is often beneficial and there is an indication, a medical indication for the procedure. So now once we have decided that a reduction is needed, we usually kind of get an estimate or a guesstimate as to how much would be needed to be removed. And in consultation with the individual and maybe her husband or partner, we go about giving a rough idea as to what incisions are required, what kind of reduction would be needed, what kind of post-operative recovery it is, and so on and so forth. Now, talking about reduction, what kinds of reductions can be done? Most people want the least amount of cuts or scars possible. So the least scarring would be there in something we call circumareolar reduction. It is extremely uncommon and it is difficult to reduce any significant amount with it. I'm saying it just because the circumareolar reduction is something everyone thinks is going to give you very little scarring if there's a cut just around the nipple or the areola, the brown or the pink area around the nipple. And everyone asks me about this. So circumareolar reduction, when you need maybe 100 or 200 grams taken out, and if the nipple areolar complex is the appropriate size and the circular incision alone would suffice. If there is a lot of droop, circumareolar does not work. If there is much more tissue to be removed, circumareolar does not work out. So that circular incision alone may not suffice for most people. Now, the other incision that is very popular and I do it most often is called a vertical scar only reduction. A vertical scar means there's a incision around the nipple, of course, the areola, and then there is one single vertical scar. This procedure was popularized by a lady in France by the name of Madeleine Lejour, and further refined by a lady from Canada. Her name is Elizabeth Hall Finley. So the differences between different procedures are, one is the incisions, and let's first talk about the incisions. The vertical one is the second one. The third one is an anchor shaped, with there's a cut around the nipple, one straight line, and then there is a long horizontal or transverse line, pretty much like the anchor of a ship. That's why it's called an anchor shaped incision or a wise pattern incision. Now that is the incisions, and that's what most of the individuals will see after the procedure. So the incisions are important. However, for deciding what kind of incisions would be required and what kind of procedures would be required, the next thing is what we call the pedicle or the blood supply to the nipple. Now, the blood supply to the nipple connection towards the inside, that is called medial pedicle, from the top called superior pedicle, from the side called lateral pedicle, or from inferiorly called the inferior pedicle. Of these, probably the most reliable pedicle is the one that is based inferiorly. However, the single vertical scar is unable to achieve that kind of pedicle. And what is the pedicle that we use for vertical scar is coming from the top and some from the inner side. And that's called a medial or superior pedicle, and it works well with the techniques described by Dr. Madeleine Lejour and Dr. Elizabeth Hall Finley. Now, that is more of a technical aspect, but there are some issues in terms of eventual cosmesis that are associated with this. Now, the superior and the medial pedicle give more fullness at the top and towards the inside, where most ladies want it. The inferior pedicle gives more reliable blood supply, but there is eventually some more volume or some more breast tissue underneath the nipple, rather than being there being a fullness at the top. So there are a couple of reasons why vertical scar is mostly preferred for ladies who are candidates for it. Then there's another technique where we actually do have the anchor shaped incisions, but we remove the nipple and areola, the brown tissue around it, and put it back on after the entire reduction as a composite graft or a skin graft. Now, that is popular for ladies who are very, 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 very heavy. The heaviest reduction that I have done, or the biggest reduction I have done, has been 11 kilos from both sides, which is about 24 and a half pounds. 24 and a half pounds from the two sides. Now, for that kind of reduction, a free nipple graft, as I just said, removing the nipple areolar complex, doing the reduction, and then putting it back on as a graft is the best technique available to preserve the blood supply as well as for healing. Now, if you don't have that huge of a reduction, if the reductions are kind of average, couple of kilos usually, or 4 or 5 pounds, including both sides, those reductions are best done with a vertical scar technique, especially if the droop is not excessive. What happens with the excessive droop is that the pedicle becomes too long and the blood supply of the nipple can become precarious or difficult because of the length of the pedicle, meaning the blood supply has to go from the base down to the nipples, and if it is too long, it becomes tough. For those individuals, a vertical scar alone technique does not suffice. You have to do an anchor shaped incision. Having said that, anchor shaped incisions can give excellent results if the patient are selected well cosmetically. But in terms of safety, they often give the better results and they are safer for huge reductions and also for a large amount of ptosis or droop. This is as far as the different techniques go. Now, what are the things that we see before we do reductions besides seeing the symptoms as well as seeing the technique that may need to be employed? We have to make sure that the individual is in good health, is not on steroids, and is not a smoker, or if she's a smoker, she needs to quit well before time, maybe 6 weeks or so. Now, reductions, when they are done, they have to be done in the optimal stage of diabetes or any other medical problems that the individual has. If she has a problem which needs steroids, those either are tapered off, or when the reduction is done, we put them on vitamin A and vitamin C to prevent the ill effects of the steroids on healing. And we also have to give some different doses of steroids. But a lot of ladies are on steroids because of back pain and shoulder pain and some kind of arthritis and so on. And we have to make sure that that is accounted for and we take due precautions. The same thing with smoking. One should quit smoking about 6 weeks before the procedure because that interferes with healing a lot. The next thing, and smoking means even doing electronic cigarettes and so on, or chewing tobacco, though that hurts as well. So all those have to be taken into account. Once the individual is in good and optimal medical condition, the reductions are done almost always under general anesthesia. And depending on the extent of the reduction, they can be done on a daycare basis, or you may have to stay for a day or two in the hospital. The average reduction that I do, they all go back home the same day. I do them all under general anesthesia, and we give them enough pain medications, sometimes a pain patch so that the pain reduction would be adequate. Ladies do not feel too much pain with the reduction, although the cuts look huge and the amount of tissue removed looks huge. But surprisingly, the pain is often less than what one would have expected after such a huge procedure. Once the initial pain is gone, individuals are very happy because weight hanging on their shoulders is gone and they feel really good. In fact, it is one of the happiest procedures that we do. All plastic surgeons, those who do breast reductions, will tell you the same thing. It is one of the happiest procedures that we do for many reasons. One is that it is a reconstructive and a procedure that relieves problems, as well as a cosmetic procedure. It makes you look better, makes you look more athletic, and the breasts are lifted up so they look more proportionate and more in the ideal position for the breast, instead of hanging way down. And they look rounder and nicer overall. So the breasts look nicer, the symptoms are less, the pain is less, and if it can be covered by insurance, the pain to your pocket is also less. Now, having said that, what are the common problems after breast reduction? The first thing that we talked about is healing. Sometimes the healing can be a problem if you're a smoker or a diabetic, or if you're on steroids or some other medications which interfere with healing. The second problem can be the blood supply specifically to the nipple and areola complex. That is often because the wrong technique has been chosen, resection has been done inappropriately. Sometimes it can happen even when the best of techniques have been followed and all right decisions have been made because of some swelling and some unknown factors. Occasionally, what happens is that you'll get a lot of blood supply into the nipple, but the drainage is bad, and the nipple would start turning blue, nipple areola complex. Now, there is a solution to it, and that is to remove the excess blood that is piling up. Otherwise, the blood supply can stop. It is like having a lot of water come in and not going out. The ingress is good, but the egress is bad. So, what you do is either you continuously removes a little bit of the blood with pinpricks or so on, or where they are available, someone can use leeches for the first couple of days, and after that, the blood supply and the drainage is restored by itself. The other problem that can happen, as with any procedure, is infection. The problem with infection in the breast is that it can also cause problems with blood supply. Why is infection slightly more common in the breast? Because the breast essentially is an open system like our gastrointestinal system or our lungs. They're open to the air from the ducts that go into the nipple. Those ducts can actually carry infection from the outside towards inside. If we were to do a surgery on the inside, say the bone in the leg, those are closed systems. Everything is closed. But here it is essentially an open system with the ducts communicating with the breast tissues. It is for that reason that I usually keep people on antibiotics after this procedure for 5 days. The first dose is given just before the patient is getting the procedure done. And for 5 days, I continue oral antibiotics for that reason. We usually give enough pain medications, including the pain patch. And at the end of the reduction procedure, also, I give a lot of local anesthetic so that there would be less pain in the immediate postoperative period. Other problems that are common with any procedure can happen with breast reduction as well, including postoperative nausea, vomiting, which needs to be managed as for anyone else. Other than anesthesia and surgery-related common complications, there can be aesthetic dissatisfaction, which means they don't look quite as good as I wanted them to look. There's a little more bulge on the sides, and things like that. Those can be improved, although one has to wait because the breast shape a lot over the first few months. The breast can kind of shape and become rounder and nicer by themselves. So a redo should not be a redo or trying to get it right as soon as it is done. If something looks out of place, should not be done. Now, occasionally there can be small wound healing problems from friction and having a small amount of non-healing or delayed healing, and that may need to be cleaned up, and the healing soon follows. Some dressings may be required, but the aesthetic result is not compromised because of these small problems. Now, one of the most important things everyone asks, and I'm going to tell you about the common complication in about 1% of the patients, and that is loss of sensation. Now, sensation which is more or less hypersensitive, hyposensitive initially for the first few weeks or months is common, but eventually most people get their sensation back to normal. The reason why the sensation can sometimes even be more is because initially, because there is a lot of droop to the nipple areola complex and the breasts are heavy, the nerves are stretched, and when you put them back up and smaller, the nerves start firing away. So any t-shirt that kind of hurts or rubs against the nipple can cause some sensation problems. Or the less sensation is because the same thing, the tissues have been stretched out and so on and so forth during the surgery. The other problems that can happen are not having um, some sensation around the skin, and that is common after every surgery, but it is only for a short duration of time. Bleeding, bruising, and so on are common, but they are usually to a very limited extent. Sometimes you can have a lot of bleeding if one of the bleeders just springs open or has not been tied up or not been controlled during the procedure, or suddenly if the pressure builds up. Then the bleeder can go on, and one can have what's called a hematoma, which may need to be drained, or a seroma, where just serous fluid sometimes builds up. It is for this reason that some people put drains in the breast reduction. I usually do not put drains, and I have not had this issue. However, if a drain is put in, it is for the individual's own safety, and one should not feel too bad that there's a little drain sticking out for a few days. It's a small plastic thing, and it's removed after a few days. In terms of the recovery, now the recovery after breast reduction, you feel like a weight is off your shoulders, and in a couple of days most people are able to do desk jobs or work on the computer and play with their phone and so on. In terms of actually working and doing most routine activities, 2 weeks are sufficient. For lifting heavy stuff, 6 weeks. And for doing excessive exercises, heavy exercises involving the chest, at least 6 weeks. In terms of going back to work, I think most people can go back to work in about 15 days or so, depending on the nature of the work. Significant others should not be touching or handling the breast for a while. I give it about 2-3 months. So one has to kind of explain that to the significant other who comes along with the individual or the patient. And having said that, eventually the cosmetic results as well as the relief is so good that most patients who have it done ask this question: why did I not think of it sooner? So if there are some questions and queries that you have, you can always contact us. It's a good source to kind of go on to plasticsurgery.org, which is the site for American Society of Plastic Surgeons, for some information. Any specific queries, please free to give us a call or contact us through any of the numbers given below. Thank you so much, and do take care.